All righty. Good afternoon, everyone, and thank you for joining us for Grand Rounds. Today, I have the distinct pleasure of introducing our speaker, Dr. Holly Humphrey. Dr. Humphrey graduated with honors from the University of Chicago School of Medicine. She completed internal medicine residency, followed by a fellowship in pulmonary and critical care medicine and a chief residency in internal medicine, all at the University of Chicago. She subsequently joined the faculty there and was appointed the Ralph W. Gerard Professor Emerita in Medicine. She served as the program director of the IM residency program, as well as the Dean of Medical Education at the University of Chicago for 14 years. Dr. Humphrey has also held numerous distinguished positions, including the chair of the American Board of Internal Medicine, president of the Association of Program Directors in Internal Medicine, and board of directors for the National Residency Matching Program. She was elected to the National Academy of Medicine, is a master of the American College of Physicians, and a fellow of the Royal Academy of Physicians. Dr. Humphrey is an accomplished lecturer and has authored over 60 original publications. I could go on and on with her many accomplishments and prominent appointments, but I will turn it over to Dr. Humphrey in the interest of time. We're deeply honored to have her here today, so please everyone give a warm welcome to a true leader in medical education, Dr. Holly Humphrey.
Thank you very much, Robert. And I only wish I were there in person because time spent with the chief residents is always a highlight, one of the most important highlights of a visit like this. And I don't know if your department chair shared with you, but a long time ago, when I was a brand new program director, he was the chief resident. And so in many ways, he taught me how to be a program director. And I can only imagine the impact that he's having on you and the other chief residents and the residents, students, and faculty. So it's a real honor and a real pleasure to be with all of you today. And when I was originally planning to join you 2 years ago, the topic that you see on the slide in front of you was not the topic I had in mind, of course, because none of us could have expected that we were going to have a global pandemic in which to learn many lessons, some of them extremely painful, but others from which I hope we can make important and long overdue changes in medical education. And that is precisely what I am planning to talk with you about today, and look forward to the conversation that we will have following my prepared remarks. So let's get started. I hope to focus on three major areas. The first is to simply describe in broad terms the impact of the pandemic on undergraduate and graduate medical education. I'd then like to pivot to some of the key lessons that we've learned during the pandemic, along with some recommendations that came from a Macy Foundation sponsored conference that we hosted last summer in July of 2021. And then finally, I will conclude with pointing out some innovations and exemplars that are already hard at work and underway that we may want to really capitalize on as a result of the pandemic. So let's start with the impact on undergraduate and graduate medical education. What exactly happened? What did we learn? And where do we go from here? So I think when things started, none of us envisioned that we would not have a single pandemic wave. But in fact, we were going to have to work our way through what has become 6 pandemic waves, and in fact, likely more to follow. So in undergraduate medical education, very quickly, our medical schools pivoted to doing the teaching and learning experience remotely. It was also the case that pretty immediately, students in many, if not most schools across the country were removed from the clinical rotations, largely for their own protection, for lack of PPE, and for the need to conserve PPE. But I'll just remind all of us that over the next several weeks, the students who will be graduating from our nation's medical schools have spent the entirety of their clinical experience in a pandemic. And I think that we have a lot to learn from the experience that they have had. And I know that in some medical schools, students had the opportunity to be at the bedside and active in the clinics, but in other schools, they have remained quite removed from the direct patient care. It was also the case that our laboratories closed, sometimes for an extended period of time, which had a significant impact on our scientific endeavors and the importance of moving the scientific enterprise forward. We also saw our high stakes secure examinations in the form of the administration of the MCAT, and then the USMLE licensing exams paused and in some cases canceled completely. There was complete upheaval in the residency application process in the early weeks of that pandemic. But that is clearly an area that I think we've learned some important lessons and can make some positive adjustments going forward. And then the interviews, both for medical school and as I transition to the GME impact for our residency programs, also moved to a virtual format. In graduate medical education, not only were those same threats to physical safety important, but also the psychological safety of our residents took on a greater impact because of their own danger that they had on a daily basis coming to work. In many cases, and certainly in New York City, a lot of the residents working in our New York City hospitals were redeployed from the areas where they had engaged in residency training. Now suddenly they were no longer in their pediatrics rotations, they were in the medical intensive care unit, or no longer in their otolaryngology rotation, instead in the medical intensive care unit. And I'll have more to say about redeployment later in this talk. We learned how to use telehealth technologies at scale in a way that many of us had experienced previously, but in those early weeks of the pandemic, we were using telehealth for direct patient care much more widely and extensively throughout America and around the world. We also saw for our residents that in many cases, their elective time was either canceled or deferred. And for those training in surgical disciplines, that had an impact on the training when the elective surgeries for the patients for whom they would otherwise be caring for and doing surgeries on, those procedures were also paused or canceled. Now, there was also a very significant impact on faculty, and I cannot begin to be completely comprehensive in the ways in which the faculty were impacted, but at a high level, we know that there were unprecedented challenges at work. The faculty were the ones making the pivot to do the teaching remotely, assessments remotely, patient care remotely. And at the same time, there was a lot of financial uncertainty, not only for our academic health centers, but for private practices across the nation. There were also unprecedented challenges at home as schools closed. There were children at home who were not able to be in school or in daycare. This obviously had a disproportionate impact on women, both personally and professionally, and we are continuing, I think, to learn many lessons from what we went through and continue to go through as a result of the pandemic. Earlier this year, in January of 2022, Van Wert and colleagues shared the results of a national survey of healthcare worker mental health after the initial peak of the COVID-19 pandemic. And so these survey responses were, as I said, following the initial peak and before the administration of vaccines. And what you see here is really not surprising. There were an enormous number of mental health symptomatology. And as I mentioned, these are healthcare workers. The largest group in this survey were physicians, but this also included a large percentage of nurses and other healthcare workers, all of whom were reporting high levels of mental health symptomatology. We also know, unfortunately, that the healthcare disparities that we have known about for many, many years became front page news during this pandemic, and they followed racial and ethnic lines, such that with an age-adjusted mortality, what you see plotted here compared to the white population age-adjusted mortality, the rates of mortality for the indigenous population, for Pacific Islanders, Latinos, and Blacks were significantly higher than those reported for white and Asian members of our population. We also know that at the same time that we were enduring the pandemic, we saw front page news over and over again about the fraying of our social fabric. At the same time that we saw unbelievable scientific advances, the pace of which we had not previously seen at any point in history with the development of the vaccine and the characterization and understanding of this virus, there was a widening gap in trust in this country. And this data comes from the National Opinion Research Center through their General Social Survey, which is a survey that they administer regularly across the country, and they track that data over time. And what you see depicted here is the percentage of Americans who have trust in the scientific community from the year 2000 to 2020. And you see a widening of that trust gap that in fact is the widest gap that we've seen in 5 decades. And perhaps not surprisingly, that trust gap is falling along partisan lines. We also know, again, unprecedented in my experience, that our healthcare workers, including our physicians, have been attacked by patients. In fact, according to Dye and colleagues, healthcare workers were 50% more likely than others to have been harassed, bullied, or hurt as a result of COVID-19, very often coming directly from patients or family members. So this pandemic was occurring simultaneously with a reawakening with the problem of racism that has been endemic in our country for hundreds of years. And the combination of the pandemic with the racist policies, practices, and attitudes in our country grew to a fever pitch. And at this point, after the prolonged duration of the pandemic and the endemic problem with racism, our healthcare workers are reporting exhaustion and mental health concerns at epidemic proportions. This combination of the biological, social, and psychological factors interact with one another in a way that is termed a syndemic by our colleagues, largely in the social sciences field. And this syndemic is exactly what we find ourselves dealing with and have been dealing with now for the past many months. So what can we learn from this? And are there things that we can actually put into practice from the horrific times that we have lived through? Some of what we learned, we already knew. Among the things that we already knew is that the social determinants of health have a disproportionate impact on the overall health of our patients, our communities, and our nation. And while we have known about this for a long time, it has been perhaps not as widely known or as well known by the general population. This statement by the World Health Organization, that the unequal distribution of health damaging experiences is not a natural phenomenon, but is a result of poor social policies, unfair economic arrangements, and bad politics. And I think the syndemic, in fact, made this the front page news that I already referred to. What about our medical education enterprise? What you see here is data collected by and reported by the Association of American Medical Colleges on a regular basis. You see the distribution by family income broken down by quintiles, with the dark purple bars being representing the quintiles of family income across America. In the lavender bars, you see the percentage of students from those families who go to college. And in the orange bars, you see the percentage of those from those quintiles who enroll in medical school as first-year students. In the hatched bars over here on the far right, you actually see within the fifth quintile of family income, the top 5%. And what is depicted in this particular graphic is that in the time period from 1988 to 2017, the top 2 household income quintiles contributed 3/4 of the matriculants to our medical schools across the country. And on this slide, we see the time period from 2007 to 2017, where about 1/3 of those matriculants come from this upper 5% of US household incomes. So I share this information because within our ranks, I'm asking the question of all of us, do we have disparities specifically for students who join our ranks and come from the lower quintiles of family income? Do those students have a fair shot? Do they have an opportunity to really feel as if they belong and to succeed in medicine as physicians when they're starting out with such a disparate experience in terms of family income? That has led David Muller and his colleagues at the Icahn School of Medicine at Mount Sinai in New York City to publish a paper in Academic Medicine last month on a framework for the social determinants of medical education, which really mimics the same framework that is used for the social determinants of health that face our patients. And in that paper, Muller and colleagues share a number of case examples of what some students went through during the pandemic when they didn't have the family safety net of resources, and some examples of how the medical school stepped in when that happened. So he and his colleagues said that the social determinants were the most important consideration in determining not only the successful entry, but the progression and completion of medical education. Now, one of the areas that he mentions and that the Macy Foundation is actually now going to take a deeper look at is the bias and discrimination in our clinical assessment systems. And this model that I'm going to share with you comes from a paper that was published in December of 2020 by Catherine Lucy and colleagues at the UCSF School of Medicine when we hosted a conference on harmful bias and discrimination in our clinical learning environments. And this model invites us to think about the ways in which we assess the clinical performance of our students by using examinations of medical knowledge during clerkship performance, for example. The intended use is to make sure that our students have achieved the minimal amount of medical knowledge across the clerkships, but there's an instrumental use where the numerical data can serve as an objective metric that allows us to rank students and assign grades and honors and a whole host of things that the exam itself was never intended to actually measure or do. And what results? Perhaps inequity results, where medical knowledge drives the clinical grade assignments rather than the other competencies that are essential for high quality patient care. And as a result, students who come from groups that have been historically underrepresented in medicine and underincluded in medicine earn fewer honors in their clinical clerkships and are less likely to receive honors or the highest designators on the dean's letter or the medical school performance evaluation. Students themselves published the paper that you see cited here, again, last month in a special supplement to Academic Medicine. And this paper was commissioned by the Macy Foundation for our conference on the impact of COVID-19 on their education. And this is just a sampling of some of what they shared with us in both their written and their oral communication. They said things such as, we believe that the impact of COVID-19 on medical education cannot be separated from the US and medicine's histories of structural racism, that underaddressed racial disparities in healthcare, socioeconomics, policing, and so much more were all laid bare and exacerbated by the viral pandemic. And they were very important contributors to our conference, and in many ways were changed by the pandemic for precisely the ways in which they have articulated their experience through these quotes. We also had program directors at our conference, and one of the program directors at our conference had this to say about the ways in which our institutions can actually be so risk averse that trainees and faculty can sometimes feel as if they cannot speak openly about what they're actually going through, and that muzzling of their perspectives can put them at particular risk when they are feeling overwhelmed and in the middle of a pandemic, for example. And while we've had a sense that that is one of the important elements of positive clinical learning environments, that people can speak openly and freely, we also know that there were examples, according to our students and our program directors, when they didn't feel during the pandemic that they could really speak openly about the fact that they were facing real dangers that their hospitals may not have been fully aware of or welcoming of in terms of their responses. So I'd like to introduce a potentially new idea, and that is, to what extent, if our patients suffer from the social determinants of health, and we can easily imagine that our students also are at risk for being vulnerable to the social determinants of medical education, those same students graduate from our medical schools and become our residents. And it's not uncommon that our residents themselves are facing the same kinds of socioeconomic pressure, loan repayments that, during COVID actually have been on pause. But the day is coming when those loan repayments will start again. And if they are from families that are unable to provide a safety net for them, moving cross country to even start a residency can be a huge financial burden to pay a first month rent and a security deposit, and to be encumbered by so much debt. And it's not uncommon for the residents, especially during the pandemic, to talk about the isolation and loneliness that was a significant part of what they were living with and going through. And then if you add and layer on top of that racist comments from patients, families, or even from their colleagues, it really became, I think, a very untenable situation. Now, I mentioned earlier that institutions, especially in the Northeast, engaged in redeployment of their residents when the pandemic was at its worst and before the vaccine was readily available. And much has actually already been written about institutional experience with redeployment. And I wanted to share a sampling of one of those papers from the Northwell Health System, where they surveyed residents and faculty who had been redeployed into a medical intensive care unit to learn what was their experience like and were there lessons that could be learned. And one of the questions on the survey is, to what extent was supervision for redeployed physicians aligned with their perceived needs? And the fellows and attendings who were redeployed into the intensive care unit felt that the supervision was adequate. The experienced residents, and experienced residents are anyone who has completed a full year of GME. So this would be people beyond that first internship year. They reported that they actually felt they had more supervision than they actually needed. But the inexperienced residents, so if you think back to March of 2020 and April of 2020, these were people who were in the March and April period of their internship, and they felt that their supervision was less than what they actually needed. A second question is, how did the perceptions of their patient care differ by level of training? Again, the attendings, fellows, and experienced residents felt that the overall quality of care was acceptable to good. But the inexperienced residents thought that the overall quality of care was worse to much worse than prior to the pandemic. And then finally, what lessons can be drawn for future surges or future pandemics or future crises? And one of the really positive elements that comes out in every paper I have read about redeployment is the strong camaraderie and culture of the informal consultations, the curbside consults that have existed time immemorial, long before the pandemic. But it was the culture of camaraderie that really got people through the pandemic and through the periods of redeployment. That the team composition was obviously very important. Having more senior residents combined with the inexperienced residents. And then it turns out that clinical decision aids, often made by chief residents and other residents, that were almost algorithms for how to manage the situations that they were facing in the intensive care unit, made a very significant difference in the overall day-to-day care for the patients. This is a framework for how adults learn that I have used throughout my career. It's a framework that was created a long time ago by a psychologist named Laurent Delos in a book that he published on guiding the journey of adult learners. And it basically is plotting challenge from low to high against support from low to high. So in periods of low support and low challenge, stasis takes place. In periods of high challenge and low support, the learner, the adult learner, will often retreat from the learning experience. If the support is really high, but the challenge is low, which certainly wouldn't be in a pandemic when people are being redeployed, one will have confirmation of their skills and knowledge and attitudes. But the quadrant that we aim to be in is this quadrant of growth, where when challenge is high, and generally practicing medicine and learning to practice medicine is a period of very high challenge, it is very important that the support is high so that adults actually learn and master adaptive learning can take place. So I want to share with you the results from another paper of residents who were redeployed. And the residents in this example also come from New York City, but in this case, they were otolaryngology residents who were redeployed to the medical intensive care unit. And in that paper, they talk about that prior to the vaccine, when they were redeployed, and in fact, all their surgeries were canceled, they said the surgeries were canceled left and right. Our training was paused. It began to feel as if we were hiding. We felt useless. And they saw colleagues from other disciplines on a daily basis putting themselves in harm's way. At this same time, they said for the first time, many of us were truly scared to go to work, to hurt the patients, to not be able to emotionally manage what we were seeing. As time went on, they said being in this apocalypse bound us together as a team. We reached out and we checked up on each other and took care of each other. We were like our own residency within a residency. And at this point in the pandemic, this group of otolaryngologies actually redeployed themselves, and they stepped forward to volunteer to work in the intensive care unit. And then their hospital actually established an intensive care unit that was run exclusively by the otolaryngology residents under the supervision of the medical intensivists. And at that point, they have a comment in their paper: we prepared daily, created cheat sheets, and shared the most up-to-date research. We regularly consulted with our critical care colleagues and recruited them to help us manage the higher level critical care issues. Some of the themes that come through not only in this paper, but in several of the papers of the residents who were redeployed was the point I already made about the importance of the camaraderie and the morale, that they were in this together. They would not make any big moves unless they were acting as a team. That the clinical decision aids were critical to their understanding and their management of patients. The supervision and specifically the curbside consults that were provided by our medical intensivists were critically important to their confidence and their ability to manage the patients, and then the support as is illustrated in this particular framework and diagram. So we are now, after 6 waves and 2 years into this pandemic, starting our 3rd year, we have residents who are graduating from our programs, some of whom have had a very, very different residency experience, especially those in surgical programs, many in our medicine residencies. And the ACGME and our certifying boards are very much engaged in conversations about the adequacy of clinical training. Are people ready to graduate from their residency programs? Have they had the adequate numbers of procedures? Do they have the knowledge, skills, and attitudes to have finished? And if they don't, then what are the options available to them? And how are we as a profession going to support our graduating residents and fellows who may not have had the experience in the disciplines in which they are training? So those are open questions that, as I said, the ACGME and the certifying boards are actively working on right now. Now, it's also the case that our interprofessional teams have faced incredible challenges. And at the beginning of the pandemic, there was this camaraderie and in many cases, very high morale and cohesiveness of our interprofessional teams, specifically with doctors and nurses working together as a team. In some institutions across the country, some members of the healthcare team were awarded hazard pay and had access to benefits that other members of the team did not have access to. And that began in some instances to create some competition. And as that happened, and the pandemic wore on into more waves, many of our teams have begun unraveling. And that unraveling has many factors associated with it, but the healthcare professions have not been immune in any way to the great resignations that we're reading about in the newspapers. Our healthcare workers aren't burning out. In many cases, they're suffering from moral injury. This great resignation was written about just last week in JAMA, making the claim that 1 in 5 physicians intends to leave their practice. And this is based on several different survey instruments, one of which was a survey that had 36,000 survey responses from clinicians across the country. That's really painting the picture of this traumatized, anxious, and depressed workforce. So let's get to the innovations and the exemplars, because things could continue to go in a very negative direction, but we have the opportunity to really learn from these experiences and capitalize on the moment in a positive way. So where do we go from here? I mentioned this conference that the Macy Foundation sponsored last July, and this is the vision statement that the 50 people who attended the conference to review the commissioned papers came up with as the vision statement. And that is that to improve the health of the people and the communities, we want to build on the lessons that we learned and the momentum that was created by the pandemic so that we commit to transforming health professions education so that it continuously adapts, achieves equity for all, and enriches the experience of giving and receiving care. Obviously, that is intended to be an aspirational vision, but one that has some concrete recommendations associated with it. Our website has the full report on it. I do not have time during the lecture today to go into the detailed set of action steps that are part of that report. But as I said, it's available on our website if you'd like to take a deeper dive. But on a high level, I'd like to just point out some of those conference recommendations. And one is that the students and residents who were part of our conference were very clear that they saw throughout the pandemic that they could be useful in ways that they had never deemed useful, but quite importantly, they saw that the learning experiences they were having should in fact be part of the required curriculum. And so one of the recommendations that we have is that students and residents should in fact have a much larger role in co-creating the curriculum with our faculty. There was also a very loud cry, again, that came from the students and residents themselves that we should adopt competency-based interprofessional education. And in some ways, those are two separate themes. And I regret on some level lumping them together. But for the purposes of this talk, I would like to underline and highlight that the competency-based education where a student or a resident acquires the knowledge, skills, and attitudes of the domain in which they're studying, and they're judged as competent and are ready to move forward, came across most convincingly and compellingly from students in the MD PhD programs, who pointed out the length of their program being so much longer than the training for others, and that they wanted the option to advance more quickly if in fact they could demonstrate competency in a variety of the domains that they were being expected to learn and master. And then the interprofessional education is obviously the ways in which our physicians learn at the very beginning of their education to work with other members of the healthcare team, the physical therapists and nurses and chaplains and social workers and all of the key people who represent the key to direct patient care, whether that's in the hospital setting, the office setting, or the community setting. The third recommendation is that we must redouble our efforts to eliminate the detrimental effects of the social determinants of medical education. This has a large bearing on the socioeconomic efforts, but also in many areas of our learning environments. And I'll have more to say about that momentarily. We also need to truly reach out and nurture the professional identity formation and personal well-being and belonging for all of our trainees and our faculty so that our learning environments are inclusive of all. And to do that, we absolutely have to be committed to and work every day to eliminate the racism and inequities that are present in our policies, procedures, and practices. So this is that co-creation recommendation that I already mentioned. And this comes from one of the papers that we commissioned for this meeting and which was published last month in Academic Medicine from Catherine Lucy at UCSF, Marianne Green at Northwestern University. And they make the really important point that by engaging students as partners, Not only do we enhance health professions education by creating opportunities for our students in innovation and curricular design and public health initiatives, but by viewing the students as co-creators and part owners of their education empowers them to gain agency and encourages their creativity, initiative, resilience, and problem-solving skills. And when I was looking around your neck of the woods, so to speak, I stumbled upon what looked to me like a really interesting potential example of a co-creation that could potentially be part of the curriculum. I don't know if this is part of your required curriculum or if it's considered a part of the experience outside of the curriculum. But the more I read about Miami street medicine and the ways in which students and faculty and other volunteers have been engaged, the more I saw this as potentially a prime example of what could be a very meaningful and dynamic co-curricular experience. It's also the case that this competency-based and interprofessional education is something the Macy Foundation has been working on for a number of years. And in fact, the foundation sponsored a conference in 2017 before I joined the Macy Foundation. And we currently have a Macy Foundation scholar, Ben Kinnear from the University of Cincinnati, who has a project working on time variable competency-based education in a residency program. Now, let me just step out of my role as the president of the Macy Foundation and tell you that when I was a dean for medical education, and before that as a program director, and I was learning about and reading about competency-based education, I was not convinced. I could not imagine how to be a program director or a dean for medical education and have my students or residents advancing at different rates from one another. The whole idea just kind of created chaos in my own mind. And I have to say, I still remain skeptical because it's one thing to have a great idea in theory, and it's another thing to be funding it, which I am doing. I am funding this. I'm curious about it, but how we actually implement this large scale, I don't know. But Ben Kinnear has a project where he's taking 2 residents per year in the residency program and allowing them to advance once they demonstrate competency. And that is already underway such that the first 2 people in this program have already met all the competencies and the milestones of that first year of residency training. Again, how to scale this remains to be seen, and we have a lot to learn from the experience that Ben Kinnear and his colleagues will ultimately share with us. The third recommendation is, how do we eliminate the detrimental effects of the social determinants of medical education? And I want to share with you some really exciting news if you don't already know this, but the group of medical students who enrolled in our medical schools across this country last fall is the most diverse group that has ever entered America's medical schools. The overall increase among Black or African-American matriculants was 21%, an 8% increase in Asian matriculants, and a 7% increase in Hispanic and Latino matriculants. Why did that happen? I think it happened for a whole host of reasons, but one of the most important may well be that more schools than ever needed to adopt a holistic admission strategy because in many cases the MCAT exam was not available. Schools made a choice to not use it. And so a holistic admission strategy is the way in which students perhaps were admitted to our medical schools in the fall of 2021. Now, it's incumbent upon all of us to align that strategy with the strategy in our learning environment so that the holistic admissions process is accompanied by a holistic retention process. And that means some attention to our learning environments, which I'll say more about momentarily. The Macy Foundation is also supporting a project underway at Yale University looking at the learning environment using data from the AAMC graduation questionnaire to assess these various domains of the learning environment through the eyes of graduating medical students. And that data, because it's a very rich national database, should give us some sense of what's actually happening in our learning environments related to the inclusiveness and whether or not there are things in our learning environments that we can correct if those environments are not inclusive in the way that we're hoping and aspiring for them to be. One of the important elements, which I already mentioned, is the assessment. How do we make assessments of clinical performance of our students and of our residents? And to what extent do we have harmful bias playing a role such that we're creating disparities when we are so much in favor of trying to eliminate disparities? We may be undermining the actual goals that we have. And so this conference, which we will sponsor later this year, aims to try to help us as a profession to eliminate harmful bias from our assessment systems. And this is the steering committee who's working on that project. The fourth recommendation is to nurture professional identity formation and personal well-being and belonging. And one of the things that we saw in a large scale way during the pandemic was presenteeism, where you show up to work when you're sick. And this has long been part of the culture of residency training. It was no longer acceptable during the pandemic for reasons of transmission of the virus. So this is a study from 2010 when residents were asked in this study, were there occasions when you think you should have taken time off for illness but did not do so? And the residents in this study, 58% worked while sick at least once and 31% more than once. And the second question from the survey was, did your schedule permit adequate time to see a physician regarding your health? And more than half said they had inadequate time. But as I said, presenteeism no longer was permitted during the pandemic. And so this is a perfect example of a change that we can make so that people are not coming to work if they're sick. The approach to well-being must be a systematic approach so that it's the system that we redesign together, and we don't put this on the back of individual residents and faculty. So I mentioned the presenteeism. Together, we need to be working very actively to manage time away from work. We need to take another look at salary and benefits, particularly when students are graduating from medical school and joining our residency programs, or leaving our residency programs and joining a fellowship. And in cases traveling across the country, reestablishing a household, often without the financial resources to do so. And then to really create a culture of support, perhaps where mental health care resources are something available to everyone. And I know at the University of Colorado, they're scheduling residents with a psychologist. The residents have an opportunity to opt out, but everyone gets scheduled proactively. And then it's in the residents' hands to decide if they keep the appointment or opt out of the appointment. And then there's a lot we could do to improve licensure and credentialing in terms of the kinds of questions that get asked when new physicians are being appointed to our medical staffs about their history of mental health or seeking care for mental health that may, in fact, in and of themselves, be highly discriminatory. This is one of the programs that developed at Columbia University during the pandemic to help support their workforce. And this was, first of all, developed for their physicians, where a psychologist or a psychiatrist would hold virtual sessions, 30-minute sessions throughout the week, where faculty could dial in and become part of this virtual community as a way to prevent the loneliness and isolation which was developing during the pandemic. And they found it to be so successful that they have continued the program even today. they also make that point in that JAMA paper published last week about the fact that when we're changing our system, the workloads have to be manageable. We have to improve conditions for all of our healthcare workers, but in particular for our physicians. I know that the electronic medical record can be a major part of our inefficiencies and the burden that physicians feel in doing their work. We need to maximize the teamwork and a culture of wellness. And then finally, that fifth recommendation is eliminating the racism and inequities in our policies, practices, and procedures. The Macy Foundation is funding an anti-racist transformation program that's being led by the group at the Icahn School of Medicine, Mount Sinai in New York. And they have a group of 11 additional institutions with whom they are collaborating in the United States and Canada to create anti-racist transformations throughout the institution. So I commend this group to you, and we're keeping an eye on the work that they're doing and the ways in which they are transforming their learning environments, because the Macy Foundation is totally committed to identify the characteristics of exemplary learning environments for the education of master adaptive learners where all who work or receive care feel that they belong. This is a schematic of the learning environment that came from our Learning Environment Conference in 2018. It's also available on our website. But it's really about, what does the environment feel like for the people who are working and caring for patients in those environments? And we know that culture turns out to be far more important than strategy, and that the culture will undermine or eat up the strategy for breakfast, lunch, and dinner. So I'm trying to put some money where my mouth is, so to speak, by announcing Catalyst Awards for transforming our GME learning environments. And we are going to launch this set of awards on July 15th. That's when our portal will open. It will close on September 15th. And these are for awards that will begin next January of 2023. We're going to be awarding 6 $50,000 awards to catalyze transformation in graduate medical education in any of the topic areas that I described today, or any other area that you might come up with that is not one that I mentioned. So some of the examples of topics for the clinical learning environment I've listed here, but you do not need to feel compelled to stick to any one of these, because I know for sure that chief residents and faculty have incredible ideas, and I invite you to put your ideas out in front of us and consider applying for one of these Transformation in Graduate Medical Education awards, so that together we can work to transform our clinical learning environments. And I'm going to stop there, and we'll be very happy to take any questions.
Dr. Humphrey, it shouldn't amaze me, because the clarity and the focus and the organization that you discuss sarcoidosis, which is what you taught me many years ago, or graduate medical education is the same level of excellence and outstanding that we've known to expect from you. And whether you're at the University of Chicago or now at the Josiah Macy Foundation, you truly are having a major impact in the world of medicine in general, and of course, medical education. We're thrilled that you came here. We're honored that you spoke to us today. I'm just busting to tell you about all the exciting, innovative programs we have here at the University of Miami, but that's not what this forum is about. We'll have that opportunity perhaps to apply. And I know Dr. Henderson will be real thrilled about the Miami street medicine slide that you showed. Armand is a nocturnist as a hospitalist, so he's either sleeping from a shift that he had last night, or he's truly out on the streets helping others right now. But he's definitely one of our stars, and thank you for recognizing him. I just have, I know Dean Ford was at another meeting. I know he was trying to come, but he hasn't signed in yet. But perhaps you can, I mean, when you were my program director and I was the chief resident, we didn't seem to have 1 in 5 residents wanting to leave medicine. Sure, we all, grumbled about it and life was tough and so forth. And there certainly are lots of challenges. And you mentioned electronic medical records and the acknowledgement of racism and so forth. But really, do you think things are going to be 10 years from now or 15 years from now any different, that there'll be even a greater percentage of individuals wishing to leave medicine? Or was it really 1 in 5 before and we just never really acknowledged it?
Yeah, great question. And I obviously don't know the answer with precision, but what I do know is that we are at a moment in time when I think we should be hungry to learn the lessons that are all around us, but we should be careful about drawing conclusions too quickly and without the same kind of rigor that we would use for qualitative or quantitative research. So I think that the amazing scientific progress that has been part of this pandemic should inspire the next generation for careers in science. Likewise, the admissions data that I shared with you about the incredibly diverse group of students who were admitted last year, who will be in the pipeline to become our residents, that represents an 18% increase in applications to medical schools. So I think, the good news is that the appetite for science and medicine, I think, has been stimulated by the pandemic. And it's our job to now create learning environments where that appetite can be realized. And perhaps the greatest concern I have is what is happening to the doctor-patient relationship and to our interprofessional teams, because the data that I've shared is unlike anything I've seen in my entire lifetime. I think it meaning, patients and their families attacking doctors and nurses is not unlike the fraying of our social fabric and the partisan nature of the lack of trust that we have as a nation. And that is what I think we need to focus very intently on, is repairing the context. But science and medicine should have a brilliant and very bright future, but we cannot exist outside of the environment in which democracy operates.
Well stated. Well, we're at the top of the hour, and unfortunately, we all have to go to clinic or something else right now, but we would love to schmooze with you much longer. I know the foundation is in excellent hands with you as the president, as well as the future of medical education in the United States. And again, we're very grateful that you came, Dr. Humphrey. We'll remain, if we can just, people that have to run, go, and those that can stay a few seconds and want to ask additional questions, please feel free to unmute yourself. And Dr. Humphrey, if we can just keep you for another minute or two.
Absolutely. Thank you so much, Roy.
Well, in the chat, there's lots of comments about how informative and how wonderful the lecture was. So thank you, Holly. And I know this wasn't a lecture that you just canned and gave it a month ago, because many of the data is just brand new off the press. So
yeah,
it's great.
Right.
Are you?
Could I ask a question?
Sure. But just identify yourself, because I don't recognize.
Hi.
Your code.
So I'm Carol Segar. I'm one of the residents from the Holy Cross regional program.
Yes. Go ahead.
So I'm actually someone who's comes from a low income socioeconomic background, and I would definitely love to know if there's any way someone like me could get access to help and do some kind of research like that, I personally want to kind of focus on that when I do become an attendee. And I wonder what you would recommend for someone who does have an interest in that kind of thing, because I do think it's something that should be discussed more to make medicine more inclusive for all different people from all different backgrounds.
Yes. So first of all, thank you for asking that question. I think that one of the things we're trying to do at the Macy Foundation is raise awareness, first of all, about this issue. And I appreciate your courage in speaking out, because to tell the real stories of people like yourself who come from a lower socioeconomic background and to really understand the challenges, I think has been eye-opening. Well, actually, let me rephrase that. I can tell you for sure it has been eye-opening, because when I began to share the observations about just graduating from medical school and moving across the country to pay a security deposit and first month rent when you are indebted and have no salary yet, very senior members of our profession were shocked to hear about this. And on the one hand, I was surprised they were so shocked, but I shouldn't have been, because if this isn't something that you pay attention to every day, you just may not realize how the people around you are really suffering. And it's often an embarrassing topic to talk about. And so that's, again, why I'm giving you some real congratulations and for speaking up. So number one, I think, is raising awareness and telling your story. And that has a lot of vulnerability associated with it. Secondly, I think we need to appeal to the policymakers, such as the accrediting bodies, the association, the Liaison Committee for Medical Education, and the Accreditation Council for Graduate Medical Education. And I have personally been very engaged in conversations with them already about this topic. And here's what I have observed so far, is we have a big chasm between our medical schools and our residency programs. And I haven't mentioned in the course of my comments today, our international medical graduates, who often face a double whammy on this accord, because they don't even have the support of a US medical school to help them make this transition. And the chasm between undergraduate and graduate medical education is one that is under the control of the profession. So I am working very hard to try to bring that chasm to a close. And we need people like yourself to stand up and tell your stories, to point out the ways in which you didn't have enough money to eat or pay your rent or move cross country. And then we need to gather a more substantial amount of data, publish it so that we can change the policies and close the chasm. And at this moment in time, hospitals who are hiring residents are saying it's the medical school's responsibility, and medical schools are saying, we don't have deep pockets, but hospitals do. It's your responsibility. And what's happening is that the students in this scenario are being required to take out even more debt. So I think, loans are under discussion with Congress right now. Physicians will probably be the very last group who will be attended to through federal legislation, if they are at all. But people like yourself who are willing to stand up and come forward will help us raise awareness and tell the stories. And I think that's where we have to begin.
So I see a couple more hands
Thank
up.
you.
I have to go to clinic, otherwise I'm going to get fired. So
Sorry, Roy. We don't want that to happen.
No, but if you don't mind, Dr. Humphrey, let Dr. Van Zulen and Dr. Jayawara ask theirs, and then, but I'm going to go.
Yes.
And say big
Thank
hug,
you.
and
Yes.
I miss you.
Thank
Take
you
care.
very much, Roy. Thank you so much. What a wonderful group you have assembled, and I'm happy to stay and answer some additional questions.
Thank you. Thank you.
Yes, thank you, Dr. Humphrey. I just wanted to follow up on I think maybe the person logged off. I just wanted to encourage the resident to look at academic medicine. They have a section where they really want to hear individual experiences.
Mhm.
And these are short, I think 400-word
Yes.
accounts. And I think this is a great place to start writing.
Yes.
About a topic that you're passionate about and share some of your experience. And then you can turn that into some research down the line. So academic medicine as a journal, it's one of the highest impact factors in medical education. And a short little 400-word personal account, this is exactly the kind of stuff that they're interested in.
I actually
Thank you.
did that, and I got something accepted the summer before I started residency.
Oh, well, there you go.
Fantastic.
I'm preaching to the choir here.
No, that I appreciate you mentioning that. That's a great, it's a great suggestion.
Hi, Dr. Franz Humphreys. Thank you very much for an excellent presentation. I'm Dr. J, as Roy said. I agree with you completely. I mean, I remember David Brooks from New York Times wrote an op-ed some time ago about this SAT, the value of SAT, saying that SAT was set up by the Ivy League schools to separate them from the others. And the value of MCAT and SAT is overvalued in medical school entrance. And I'm not saying about SAT for medical school entrance, but in general. So my point is that we tilt this whole thing towards the privileged class, because when you medical school entrance, I mean, we ask, do you do international trips? Do you do this? You do academic research? But a guy who is struggling with the resident who just said, who is looking after her bipolar father or mother, or who is trying to pay rent, that life experience is never seriously considered in many schools for admission. As you said, it should be more, rather than trying to get an Einstein into medical school, you should get Mother Teresa into medical school. I want to just thank you for bringing this out.
Oh, thank you. That's those are beautiful comments. And I think you just made the point very, very well that I was trying to make, that we say as a profession, and I think we believe as a profession, that we really want diversity in our ranks so that we can more effectively care for a very diverse and increasingly diverse patient population. But we cannot continue to stand behind that goal unless we are equally committed to taking care of all of those diverse medical students who become our residents in ways that require a whole host of ways of support, but including, and importantly, financial resources. And the chasm that exists in our schools and in our residency programs among those who come from really wealthy families and those who do not, it's a story that isn't really being talked about that much. But people are suffering, our own residents within our profession and students are suffering. And so I hope that together we can raise awareness and have some accountability that has some dollars behind it to really help this group.
Thank you.
Dr. Humphrey, the one other comment I had wanted to make was about the group of residents from another specialty. I don't remember which one, that decided to volunteer for the ICU. And I was just struck even watching some of the images from what's happening in Ukraine. But in helping the residents and our medical students, I mainly work with the medical students, in finding like Viktor Frankl's, that search for meaning, and how they found that meaning.
Yes.
Right? And I would suspect that among those residents, the view of wanting to quit is very different, because they found meaning in the work that they do. So, we try to do that with our medical students in some small ways, finding the humanism and making sure that they connect, stay connected with that.
Yes, thank you for mentioning that. That was a group of otolaryngology residents who, at the beginning of the pandemic, they were sidelined. They had no cases. They were at home, and meanwhile, they saw their fellow friends in internal medicine, working their hearts out. And then after a few weeks, it was those otolaryngology residents who volunteered to go to the ICU. And one of the things that they said in their paper that I did not highlight, but it was very aligned with what you just said about meaning. And they said that they realized that their days in the ICU caring for critically ill patients, they needed technical knowledge that the attending physicians helped them with and the crib sheets helped them with. But what they were spending the majority of their time doing was having telephone conversations with family members who were not allowed to come into the hospital and see their loved one, and that the residents became the conduit for information. And not only did they become the conduit for information, but they became the conduit for what would be, and I don't remember their words exactly, but the most important and memorable conversation that a family member would have with a healthcare provider when they learned of the passing of their loved one. And these ENT residents embraced that challenge as they recognized the importance of communicating, the final wishes or the final words or the final moments of the loved one when families were not allowed to be in the hospital. And, they had exactly the transformation in terms of meaning and the role that they were playing. They thought they went to the hospital to become surgeons, which of course they did. But what they found in those moments and in those weeks is that they were most effective in being healers through their words and their connections with family members.
Yeah, it's very interesting. We, I direct medical student training in geriatric and palliative medicine, and we saw that in palliative medicine, definitely.
Yes.
Trying to make those connections with the family is super important. Yeah.
Yeah. Well,
Any other questions for Dr. Humphrey from the group? Well, thank you all for being here. Dr. Humphrey, I don't know if you remember, right before COVID, we had a conversation when you were about to come down, and I had reached out to you
yes.
With our Women in Academic Medicine
Yes.
group and the medical education. And I will at some point reach out to you again and to see how we may rope you in doing something for the department. We now have a Department of Medical Education.
Oh,
and so we are an Academy of Medical Education scholars and faculty interested in the Macy Foundation grants. So I will reach out to you in the near future, I hope, and maybe have another conversation about what we can do together.
Yes, thank you. And I do remember your name, and it's nice to now at least put a face virtually to your name.
Yes.
So I will look forward to that.
Wonderful. Well, thank you all for being here again.
Thank you.
And I think we can probably end the meeting unless there's any last minute announcements or comments. All righty, Laura,
Okay.
thank you. We're all good to go.
Thank you.